Welcome back to the deep dive. Today we are getting into a really critical topic, one of the most comprehensive areas in all of med-surg practice, really.
And we're talking about the management of oncologic disorders.
Exactly. And for this, we're using a single authoritative source, Chapter 12, which is designed to give you, the nursing professional, all that high-yield, clinically relevant knowledge you need.
Right, to navigate the entire cancer care trajectory. That's really our mission today.
Yeah.
To just distill the essence of this chapter.
And it covers so much ground.
Everything. We're starting with the tiny cellular differences that define what makes a cell malignant.
And then moving all the way through screening, treatments.
Detailed treatments, chemo, immunotherapy, all of it. And we'll end with the priority nursing interventions for those acute complications and, end-of-life care.
Because oncology nursing really does span everything.
Prevention, diagnosis, cure, control, palliation, and survivorship. If cancer can hit any body system, then oncology nursing touches every single specialty.
Okay, so before we dive into all that complexity, let's get our language straight. The book really emphasizes a vocabulary check first.
It's essential. We all have to be on the same page. Let's start with the cell itself.
Okay.
You have a benign tumor. It's contained. It can't spread.
And then the opposite.
A malignant tumor. That one is all about relentless, abnormal proliferation. And a key sign of that malignancy is something called anaplasia.
Which means?
It's a total lack of normal cell characteristics. The cells are just disorganized. They don't look like they're supposed to.
And what about the process, how the disease actually starts and then spreads?
Well, the start is carcinogenesis. That's the whole three-step transformation process.
Okay.
And once that's complete, the cancer can metastasize. That's the spread to distant sites, usually through the lymph system or the blood.
Right. And as nurses, we spend so much of our time managing the fallout from treatments. What are the key terms for side effects?
You absolutely have to know myelosuppression. That's the suppression of bone marrow function, which leads to low blood counts.
And there's a critical point in time after chemo, right?
The nadir. It's the lowest point your blood cell counts hit, especially neutrophils. It usually happens about 7 to 14 days after a treatment cycle.
The most dangerous period.
By far. And for safety with all these, we have to know about vesicants. A vesicant is any drug that can cause blistering, inflammation, even tissue death if it leaks out of the vein. It's an emergency.
And finally, the concept that's really driving all of modern oncology.
Precision medicine.
So personalized care.
Exactly. It's about moving away from one-size-fits-all toxic chemo. We use genetic mapping to find the unique molecular drivers of a patient's specific cancer, and then we pick treatments that target those drivers.
Okay, that's a great foundation. Let's get into the malignant process itself. It's not enough to just know the definition of benign versus malignant.
Right, you have to understand the clinical consequences. Those differences are what determine the prognosis, the treatment, everything.
So let's unpack Table 12-1. What are the major distinctions in how these tumors behave?
The differences are just stark, and they explain why cancer is so deadly. Take differentiation and anaplasia.
Okay.
A benign tumor is usually well differentiated. The cells look like the normal tissue they came from.
They're recognizable.
Right. A malignancy, though, is often highly undifferentiated. It's anaplastic. Those cells might bear zero resemblance to their tissue of origin.
And clinically, that tells us something important.
It tells us about speed. The less differentiated a tumor is, the faster it grows, and the more malignant its potential.
And that change in structure affects the growth pattern, too.
Absolutely. Benign tumors grow by expansion. They just push against things. And they're often in a nice fibrous capsule.
Which makes them easier to remove.
Much easier to get a clean excision. Malignant tumors, on the other hand, are invasive. They actively infiltrate surrounding tissue. They ignore what's called contact inhibition.
The signal that tells cells to stop growing when they bump into each other?
Yes. They just don't care. They grow aggressively at the edges, which makes getting clean surgical margins a huge challenge.
And then, of course, the big one, the ability to metastasize.
That's the defining feature of a malignancy. The cell figures out how to get into blood and lymph walls, travel, and set up shop in distant sites.
Which is why the treatment has to be systemic, like chemotherapy.
Exactly. You can't just treat the local spot anymore. And this all leads to the general effects. A benign tumor is usually just a local problem, unless it's, pressing on your brainstem.
Right.
But malignant tumors trigger systemic problems. Weakness, fatigue, anemia, a massive inflammatory response, and that devastating thing called TACS.
Cancer-related anorexia-cachexia syndrome.
It's a severe wasting process. It's not just not feeling hungry. It's your body actively breaking itself down. driven by all these inflammatory cytokines.
Wow. Okay, so that sets the stage for carcinogenesis, the actual process of transformation. How does a normal cell start this journey?
It all begins with initiation. A carcinogen, a chemical, a physical agent like radiation or a virus, causes a permanent, irreversible mutation in the cell's DNA.
And the body's defenses fail.
Normally, your cell's repair mechanisms would fix it, or the cell would be forced into apoptosis, cell death. But if it escapes that, the mutation is there for good.
The book mentions a complete carcinogen.
Right, that's something like cigarette smoke or asbestos. It has the power to both initiate the damage and promote the growth later on.
So the DNA damage is done, but the cancer is still quiet. That brings us to promotion.
Yes, and this phase is so important because it's reversible.
Reversible. How?
During promotion, the initiated cells start to proliferate, but only when they're repeatedly exposed to promoting agents. This can happen after a really long latency period, sometimes decades.
So if you remove the promoter,
You can stop the process. If you quit smoking, you remove the promoter, and you can prevent the clinical emergence of cancer. This is a huge window for prevention.
but if it continues, we get to progression. And this is where it gets its real power.
Progression is where the altered cells become truly malignant. They learn all the nasty tricks. The most critical is stimulating angiogenesis.
Creating their own blood supply.
Exactly. Recruiting new blood vessels to feed the tumor with oxygen and nutrients. They also get the full ability to invade and metastasize. It's the final, irreversible step.
And this whole process is really controlled by genes that act like the cell's accelerator and brake pedal.
That is the perfect analogy. The accelerators are the proto-oncogenes like EGFR or KRAS. These are normal genes.
But when they mutate,
They become oncogenes. They get stuck in the on position, just flooring the accelerator and driving uncontrolled growth. A KRAS mutation, for instance, is linked to really aggressive pancreatic, lung, and colorectal cancers.
and the brakes,
The brakes are the cancer suppressor genes. Think of BRCA1 and BRCA2. Their job is to monitor cell division, hit the brakes, and initiate repair or cell death if something's wrong.
so when they mutate, the brakes fail.
The brakes are gone, and you get unchecked growth of these mutant cells. A patient with an inherited BRCA mutation, for example, has a much higher lifetime risk of multiple cancers because every cell in their body is missing one of its brake pedals.
So let's talk about etiology. What are the specific risk factors that pull that trigger? Starting with viruses and bacteria.
It's pretty wild to think that about 10 to 12% of all cancers worldwide have infectious cause.
Like HPV.
HPV is a big one. It inserts its DNA into the host cell and drives proliferation, leading to cervical and some head and neck cancers. Then you have hepatitis B for liver cancer and EBV for Burkitt lymphoma.
And bacteria?
H. pylori is a major one for stomach cancer. Chlamydia is linked to ovarian and cervical cancers, often because they cause this chronic smoldering inflammation.
Next up, physical agents. We all think of the sun.
UV radiation, definitely a major cause of skin cancers, but also ionizing radiation. That could be from repeated diagnostic X-rays or, ironically, from prior radiation treatment for another cancer.
And the book points out radon gas.
Yes, background radiation.
Oh.
Radon is a naturally occurring gas that can build up in homes, and it's specifically linked to lung cancer. It really highlights the need for home testing and ventilation, and just chronic irritation anywhere in the body can kick off the process too.
When we get to chemical agents, the text is crystal clear about the #1 priority.
Tobacco use. It is the single most lethal chemical carcinogen. It's responsible for about 30% of all cancer deaths.
And it's not just lung cancer.
Not at all. It's linked to 12 different types of cancer. And as nurses, we have to be just as vigilant about environmental tobacco smoke or secondhand smoke. It increases lung cancer risk in non-smokers by 20 to 30%.
What about smokeless tobacco?
Still incredibly dangerous, high risk for oral, pancreatic, and esophageal cancers.
And the new kid on the block, e-cigarettes or ENDS.
Right. We don't know the long-term cancer risk yet, but they aren't harmless. They contain nicotine and other harmful chemicals. We have to be cautious. And of course, there's still major concern about occupational exposures to things like asbestos, arsenic, and benzene.
Let's shift to genetic and familial factors. This is really the heart of precision medicine.
About 5 to 10% of adult cancers are linked to these inherited syndromes. The key here is that it's a germline mutation.
Meaning it's in every cell in the body.
Every single cell. And it's passed down usually in an autosomal dominant pattern. Chart 12:1 gives you the classic hallmarks to look for.
Like what?
Cancer onset before age 50, cancer in multiple first-degree relatives, multiple different types of cancer in the same person. When you see these patterns in a family history, that's a huge red flag
And that's when you refer for genetic counseling.
immediately, especially for things like BRCA1 and 2, which dramatically increase the risk for breast, ovarian, and prostate cancer. The nurse's role in taking a detailed family history is just critical here.
Beyond genes, lifestyle factors play a huge role.
A huge and modifiable role. About 16% of all cancers are linked to lifestyle. Obesity is a massive driver.
For which cancers?
Breast, colon, rectum, esophagus, kidney, pancreas. The mechanism is complex, but it involves chronic inflammation and altered hormone levels, especially estrogen and insulin.
And diet.
Diets high in fat, heavy alcohol use, processed meats with nitrates. Heavy alcohol use on its own is linked to cancers of the mouth, throat, liver, breast. The list goes on.
And what about hormonal agents?
Right. Some cancers are hormone sensitive, meaning hormones promote their growth. Breast, prostate, and endometrial cancers are the big ones.
So things that increase hormone exposure increase risk.
Exactly. For women, that means a longer reproductive life starting periods, early, late menopause, never having children, or having them late in life. All of these increase lifetime exposure to estrogen cycles.
And hormone replacement therapy.
A critical point. Combination estrogen and progesterone HRT significantly increases breast cancer risk the longer it's used. The good news is that the risk drops substantially once you stop the therapy.
So the body's last defense against all of this is the immune system. How is it supposed to work?
It's a process called immune surveillance. The key players are your T lymphocytes. They are constantly patrolling, looking for cells that are displaying abnormal antigens on their surface, these tumor-associated antigens or TAAs.
And when they find one?
They sound the alarm. They release cytokines, which call in the heavy hitters, the cytotoxic T cells, which are the direct killers. They also recruit other cells like macrophages and natural killer cells to help clean up.
And we know this system is important because of immunocompromised patients?
Exactly. Patients on immunosuppressants after a transplant or patients with HIV/AIDS, they have a much higher incidence of cancer because their surveillance system is down.
So if the system is so sophisticated, how do cancer cells manage to evade it? They must be masters of disguise.
They absolutely are. One way is they just alter their cell membrane so the immune cells can't get a good grip to recognize them.
But there's a more advanced trick they use.
Yes, and this is the target of modern immunotherapy. They express molecules on their surface, like the PD-1 ligand. This ligand acts like a secret handshake. It binds to the PD-1 receptor on the T cell and sends a signal that basically says, hey, I'm one of you. I'm a normal cell. Stand down.
It turns the T cell off.
It completely deactivates the T cell. It induces immune tolerance, so the tumor can grow completely unchecked, hidden in plain sight. They also release inhibitory cytokines to create this whole immunosuppressive bubble around themselves.
Incredible. Okay, let's move on to how we fight back. Section 2, prevention, detection, and diagnosis. The foundation here starts with prevention.
Always. Now we break it down into primary, secondary, and tertiary.
Let's start with primary prevention. This is about stopping the cancer before it ever starts.
Right. Pure health promotion. We're talking about encouraging healthy diets, maintaining a healthy weight, physical activity, following the guidelines in Chart 12-2.
But the most powerful tools are immunizations.
Without a doubt. The nurse has to be a huge advocate for the HPV vaccine, which can prevent the vast majority of cervical cancers and some head and neck cancers, and the HPV vaccine for liver cancer. This is true prevention.
Then we have secondary prevention. This is all about screening and early detection in people who don't have any symptoms.
And these guidelines in Table 12-3 are always changing, so as a nurse, you have to stay current.
Let's run through the big ones. Breast cancer.
For average-risk women, it's an annual mammogram from ages 45 to 54. After 55, they can switch to every other year as long as they're in good health.
Cervical cancer has different rules for different age groups.
It does. From 21 to 29, it's a pap test every 3 years. From 30 to 65, the best practice is co-testing. That's a pap plus an HPV DNA test every 5 years.
And for colorectal cancer, the starting age just dropped.
Right, it's now 45 for everyone. This reflects the scary rise in early onset colon cancer. And patients have options.
Like what?
They can do annual stool-based tests or visualization tests like a flexible sigmoidoscopy every 5 years. But the gold standard, the most comprehensive option, is still a colonoscopy every 10 years.
Lung cancer screening is very targeted, though. Why only for heavy smokers?
It's a risk-benefit calculation. The screening uses a low-dose CT scan, and it's only recommended for people aged 55 to 74 with at least a 30-pack-year smoking history who are either still smoking or quit within the last 15 years.
Because the risk of false positives is high.
Exactly. The benefits only outweigh the risks in that very high-risk group, and it's critical that any screening program has to be paired with smoking cessation counseling.
Finally, prostate cancer.
This one is all about shared decision-making. Starting at age 50 or 45 for African American men, there needs to be a conversation with a provider about the pros and cons of PSA blood testing and a digital rectal exam. There's a real risk of overdiagnosis and unnecessary treatment.
And after all that, we have tertiary prevention. This is for people who've already had cancer.
Tertiary prevention is all about survivorship. The nurse's role here is surveillance. You're monitoring for occurrence of the original cancer, but also screening for the development of second malignancies.
Caused by the treatment itself.
Sometimes, yes. Treatment-related leukemias or lymphomas can show up years after certain types of chemo or radiation.
So when cancer is suspected, we move to diagnosis and evaluation. The testing can seem overwhelming for patients. What are the goals here?
There are four main goals. First, confirm there's a tumor and figure out how big it is. Second, determine if it has metastasized. Third, and this is non-negotiable, get tissue for analysis.
The biopsy.
Right, no tissue, no issue. And fourth, you have to evaluate the function of major organs to see if the patient can even tolerate the treatments you're planning.
And the nurse's role during all this.
Managing extreme anxiety, explaining complex tests in simple terms, and making sure the information the patient is getting is consistent.
And these advanced tests, like tumor markers, really guide treatment now.
They're essential for precision medicine. Finding a HER2 gene amplification in breast cancer, for example, tells you that the patient will likely respond to the targeted drug trastuzumab.
And imaging.
Imaging gives us the map. CT, MRI, and especially P-fusion scans, which are incredible. They combine the anatomic detail from a CT with the metabolic activity from a PET scan.
So you can see not just where the tumor is, but how active it is.
Precisely. It helps find tiny spots of cancer you might otherwise miss.
Once you have the tissue, it's all about staging and grading. Let's break those down. They're not the same thing.
Not at all. Staging is about the anatomic extent. Where is it and how far is it spread? We use the TNM system for this.
TNM?
T is for the primary tumor, its size, and how far it is invaded. N is for regional lymph nodes, are they involved? And M is for metastasis, is their distance spread?
So that tells you the physical map of the cancer. What about grading?
Grading is what the pathologist does under a microscope. It's about how abnormal the cells look, their differentiation.
How much they look like the normal tissue they came from.
Right. Grade O tumors are well differentiated. They look pretty normal. They're less aggressive. Grade 4 tumors are poorly differentiated or anaplastic. They're highly aggressive and usually have a poorer prognosis.
And the TNM and the grade together give you the final stage, I through IV.
Exactly. And with that full picture, the team can establish the goals of treatment. And there are really only three options.
Cure, control, or palliation.
Right. And your nursing care changes dramatically depending on that goal. Is our goal complete eradication, or are we trying to contain it and manage it like a chronic disease? Or are we focused purely on symptom relief and quality of life?
It's a fundamental question. Let's move into those treatment modalities, starting with surgery.
Surgery is often the first and best shot. It can be used for a bunch of different reasons.
Let's start with diagnostic surgery. The biopsy.
This is how you get the definitive diagnosis. If the tumor is small and easy to get to, you might do an excisional biopsy, where you take the whole thing out plus a little margin of normal tissue.
And if it's too big?
Then you do an incisional biopsy, where you just take a wedge for analysis.
Yeah.
Or you can do a less invasive needle biopsy in the outpatient setting.
The chapter highlights a major innovation here, the sentinel lymph node biopsy. Why is this such a big deal?
It's a total game changer, especially in breast cancer and melanoma. The surgeon injects a dye near the tumor to find the sentinel node. That's the very first lymph node that drains the tumor. If that node is free of cancer, it's highly unlikely the cancer has spread further into the lymph system. This allows patients to avoid a full, debilitating axillary lymph node dissection, which has a high risk of causing lymphedema.
So after diagnosis, surgery can be the primary treatment.
Right. The goal is to remove it all. That could be a local excision for a small tumor or a wide or radical excision.
Which is much more extensive.
Yes. There you're taking the primary tumor, the lymph nodes, and maybe even adjacent structures. And you have to prepare patients for the fact that this can be disfiguring or affect function, which often means they'll need follow-up reconstructive surgery.
And technology is making all of this better.
Oh, for sure. We have advanced techniques like cryoablation, which freezes tumors, and RFA, which heats them. And the rise of minimally invasive and robotic surgery has been huge for patients. Less blood loss, less infection, much faster recovery times.
Surgery also plays a role even when a cure isn't possible.
That's palliative surgery. The goal shifts completely to relieving symptoms. Things like debulking a tumor that's causing an obstruction, placing a feeding tube, or cutting a nerve root to control pain.
There's also prophylactic surgery.
Right, like a prophylactic mastectomy for a patient with a BRCA mutation. This is a huge decision, removing a healthy organ to prevent a future cancer. It requires so much careful counseling.
So for the nurse managing these patients, what's the priority?
Beyond the usual pre-op and post-op care, you have to think about the whole picture. Has this patient already had chemo or radiation? Because that dramatically increases their surgical risks.
And communication.
Communication is everything. Managing the intense anxiety, making sure the patient understands the plan and what to expect, and ensuring the whole team is on the same page.
Okay, let's switch gears to radiation therapy, used in about 60% of patients. How does it actually kill cells?
It uses high-energy ionizing radiation to damage the DNA of the cancer cell. The damage is so severe that the cell can't repair itself, and it either dies outright or undergoes apoptosis.
And some tissues are more sensitive than others.
Yes, it's all about how fast the cells are dividing. Tissues with a high mitotic rate are the most sensitive. So that's your bone marrow, the lining of your GI tract, hair follicles, lymphatic tissue.
Which explains all the common side effects.
Exactly. And tissues that divide slowly, like muscle and nerve, are much more resistant to radiation.
The delivery is almost always fractionated. Why is it broken up into small daily doses?
There are two critical reasons. First, it gives the healthy, normal tissue around the tumor a chance to repair the damage between treatments.
Okay.
Second, it actually makes the tumor more vulnerable. As cells in the tumor die off, the ones on the periphery get better oxygen supply, which pushes them into the part of the cell cycle where they're most sensitive to radiation. It maximizes the cell kill.
There have been so many advances in external beam radiation therapy, or EBRT. What should nurses know?
It's all about precision now. We have things like image-guided radiation therapy, or IGRT, where we're taking images in real time during the treatment to make sure the beam is perfectly aimed.
And SBRT.
Stereotactic body radiation therapy. That's where we deliver very high, very precise doses of radiation over just a few days to treat small, well-defined tumors.
And the most advanced is proton therapy. What makes it so different?
The physics of it are amazing. Protons deliver their maximum dose of energy right at the tumor. It's called the Bragg peak, and then they just stop. There is virtually no exit dose of radiation beyond the tumor.
So it spares healthy tissue behind the tumor.
Perfectly. It's incredibly valuable for treating tumors right next to critical structures like the spinal cord, the heart, or the brain.
And then there's internal radiation or brachytherapy.
Right. This is where we place the radioactive source directly inside or right next to the tumor. It delivers a super high dose locally with a very rapid drop-off in dose to surrounding tissues.
And the source can be temporary or permanent?
Exactly. And we also have systemic radiotherapy, like drinking radioactive iodine for thyroid cancer. The isotope naturally travels to the target tissue.
For brachytherapy, the nurse's priority is safety. What are the 3 golden rules?
It all comes down to time, distance, and shielding.
Okay, break those down.
The patient is in a private, isolated room. Time. You limit your time in the room. Visitors are usually capped at 30 minutes a day. Distance. You maximize your distance from the source. Stay at least 6 feet away when you're not providing direct, hands-on care.
And shield.
Use lead shields whenever possible. And all staff have to wear a dosimeter badge to track their exposure.
And who's absolutely not allowed in the room?
No pregnant staff, no pregnant visitors, and no children.
Yeah.
Ever. And if an implant gets dislodged, you never, ever touch it with your hands. Use long-handled forceps, place it in the leak container, and call the radiation safety officer immediately.
Let's talk about the acute toxicities of radiation.
The #1 complaint across the board is fatigue. It's profound and can last for months. The most visible toxicity is on the skin radiodermatitis.
It can range from just redness to really severe breakdown.
Yes. From mild erythema and dry flaking all the way to moist desquamation where the dermis is exposed and weeping, and even ulceration.
So what are the key nursing interventions for that skin?
You have to be militant about preventing irritation. Absolutely no soaps, perfumes, deodorants, or cosmetics in the treatment field. Use only lukewarm water. No rubbing, no scratching.
In sun exposure.
Avoid sun exposure on that area for life. For moist desquamation, you use non-adhesive dressings, and you do not break any blisters.
What about other areas?
Radiation to the head and neck causes terrible stomatitis, or mouth sores and xerostomia, or dry mouth. Radiation to the abdomen causes nausea, vomiting, diarrhea, and if a bone marrow-rich area like the pelvis is in the field, you can see significant myelosuppression.
And these are different from the late effects.
Yes, late effects pop up months or even years later. They're usually permanent and caused by fibrosis and scarring. Things like pulmonary fibrosis, heart damage, CNS changes. They're a huge part of survivorship care.
Okay, let's move on to the big one, chemotherapy. This is our weapon against systemic disease. It works on the cell kill hypothesis. What is that?
The idea is that a single dose of chemo doesn't kill 100% of the cancer cells. It kills a percentage of them. So you need repeated cycles to keep knocking the tumor burden down bit by bit until it's small enough for the patient's own immune system to hopefully wipe out the rest.
And it targets actively dividing cells.
Right. Tumors with a high growth fraction are the most sensitive, and we use this by targeting different parts of the cell cycle.
Some drugs are cell cycle specific, some are not.
Exactly. Some only work in the S phase, when DNA is being synthesized. Others only work in the M phase, during mitosis. And some, like alkylating agents, can hit the cell at any point.
Which is why we use combination therapy.
Yes. You hit the cancer with drugs that have different mechanisms of action. It increases the cell kill and makes it much harder for the tumor to develop resistance.
Let's talk toxicities, because this is where nursing lives. What are the big ones for the major drug classes in Table 12 to 7?
Okay. Alkylating agents like cisplatin cause severe myelosuppression and really bad nausea and vomiting. Cisplatin is also famous for being highly toxic to the kidneys and for causing hearing loss.
And the red devil?
Toxirubicin, an anti-tumor antibiotic. The big one there is cardiotoxicity. It can cause irreversible heart damage, so patients have a maximum lifetime dose that we can never exceed. We have to monitor their heart function constantly.
What about the antimetabolites?
They often cause really painful stomatitis and mucositis, severe myelosuppression, and sometimes something called hand-foot syndrome, which is painful redness and swelling on the palms and soles.
And the drugs that mess with mitosis?
And the mitotic spindle inhibitors, like vincristine and the taxanes, their dose-limiting toxicity is peripheral neuropathy, numbness, tingling, pain. It can be debilitating and sometimes permanent.
Let's talk about administration safety. The biggest immediate danger is extravasation.
Extravasation is a true nursing emergency. A vesicant chemical leaks into the tissue and can cause necrosis, destroy tendons, and lead to permanent loss of function.
So prevention is everything.
Everything. Never use a peripheral IV in the wrist or hand for a vesicant. Ever. For these drugs, you need good central venous access, like a PICC line or an implanted port.
And if you suspect it's happening,
Stop the infusion immediately. Don't pull the IV out yet. You follow your facility's protocol, which might involve trying to aspirate drug back, injecting an antidote, and applying cold or warm compresses. You have to have an extravasation kit at the bedside.
we also have to watch for hypersensitivity reactions.
Yes, these can happen within minutes and range from a mild rash to full-blown anaphylaxis. You monitor vital signs closely, and at the first sign of a reaction, trouble breathing, hives, a drop in blood pressure, you stop the infusion and hit the emergency button.
Okay, let's go through the major systemic toxicities, starting with the most common. Chemo-induced nausea and vomiting, or CINV.
Right. It's a huge quality of life issue. We classify it by when it happens.
Yeah.
Acute CINV is within the first 24 hours. Delayed CINV can pop up days later. And then there's anticipatory CINV.
Which is psychological.
It's a conditioned response. The patient just smells the alcohol swab in the clinic and starts to feel sick. Management is all about prevention, using a combination of powerful antiemetics based on how immunogenic the chemo is.
Now for the most life-threatening toxicity, myelosuppression.
Neutropenia, thrombocytopenia, anemia. The lowest point, the nadir, is about 7 to 14 days post-treatment. This is when the patient is at the highest risk.
And what is the absolute #1 safety alert here?
Febrile neutropenia. A fever over 101.1 or a sustained temp over 100.4 in a neutropenic patient is an emergency. You get cultures and you start broad-spectrum IV antibiotics immediately. Mortality skyrockets with every hour of delay.
What about the renal system?
Some drugs are directly nephrotoxic, like cisplatin, so you have to hydrate patients aggressively. But the other big renal threat is tumor lysis syndrome, or TLS.
This happens when you have a fast-growing cancer and the chemo works too well.
Exactly. A massive number of cancer cells die all at once and dump their contents into the bloodstream. You get hyperkalemia, which can stop the heart, and hyperuricemia, which can cause acute renal failure.
How do you manage TLS?
You prevent it. In high-risk patients, you start aggressive IV hydration and drugs like allopurinol or rasburicase before you even give the chemo, and you monitor their labs and cardiac rhythm like a hawk.
Let's talk about a very specific neurotoxicity. What's the deal with oxaliplatin?
So, many drugs cause peripheral neuropathy, but oxaliplatin has this unique acute neurotoxicity called pharyngolaryngeal dysesthesia.
What is that?
It's a severe sensitivity to cold that causes a feeling of throat tightness, numbness, and tingling. It's terrifying for patients.
So the nursing teaching is critical.
You have to tell them, for the next 3 to 4 days after your infusion, avoid all cold fluids, don't breathe in cold air, no ice. It's a huge safety point.
We also have to acknowledge chemo brain.
Yes, this cognitive impairment is real. It's a persistent decline in attention, memory, processing speed. It's not just in their head. As nurses, we need to validate this and look for contributing factors like anemia or fatigue that we can fix.
Let's briefly touch on hematopoietic stem cell transplantation, or HSCT.
This is used for blood cancers and some solid tumors. We used to harvest bone marrow, but now we mostly collect stem cells from the peripheral blood via apheresis. It's easier on the donor, and engraftment is faster.
We have allogeneic and autologous transplants. What's the key difference in risk?
Allogeneic is from a donor. The hope is that the donor's immune cells will attack any remaining cancer. That's the graft versus tumor effect. The huge risk, though, is graft-versus-host disease, or GVHD, where the donor cells attack the patient's healthy tissue.
And autologous.
That's using the patient's own stem cells. You eliminate the risk of GVHD, but there's a chance you could be reinfusing some hidden cancer cells back into the patient.
And that period right after transplant is incredibly dangerous.
The patient has no immune system. The highest risk of death in those first couple of weeks is from sepsis and bleeding. We're on high alert for any sign of infection.
Okay, on to the newer, more precise treatments. Immunotherapy and targeted therapy.
This is the future. Immunotherapy is all about using the body's own immune system to fight the cancer.
The early versions were pretty nonspecific.
Right, like BCG for bladder cancer, which just causes a general local immune flare-up, or using cytokines like IL-2, which can be effective but also incredibly toxic, causing things like capillary leak syndrome.
But then we got monoclonal antibodies, the mAbs.
These are much more targeted. They're engineered to lock onto a specific antigen on the cancer cell surface and either block its function or mark it for destruction.
And the real revolution came with the immune checkpoint inhibitors. Can you explain again how they work?
So we talked about how cancer cells use that PD-L1 molecule to shake hands with the T cell and turn it off. Checkpoint inhibitors are drugs that physically block that handshake.
They take the brakes off the immune system.
Exactly. They unleash the patient's own T cells to go after the cancer. It has completely changed the game for melanoma, lung cancer, and many others.
But this new mechanism creates a whole new class of side effects. Immune-related adverse events, or IRAEs.
This is probably the single most important thing for a nurse to understand about these drugs. These are not chemo side effects. They are autoimmune side effects. The revved-up immune system starts attacking healthy tissue.
And it can be any organ.
Any organ. Colitis, pneumonitis, hepatitis, thyroiditis. And the treatment is not supportive care. The treatment is high-dose corticosteroids to shut down that immune response.
Then we have the even more personalized CAR T-cell immunotherapy.
This is cell engineering. We take a patient's T cells out of their body, genetically modify them in a lab to recognize a specific cancer antigen, grow billions of them, and then infuse them back into the patient. They become a living drug.
But the toxicities are severe.
Life-threatening. The two big ones are cytokine release syndrome, or CRS, which is a massive systemic inflammatory storm that can cause fevers, hypotension, and organ failure.
And the other?
Acute neurologic toxicities. Confusion, seizures, even cerebral edema. These patients require intensive, specialized care, often in an ICU.
And finally, we have the targeted therapies. The small molecule drugs, the NIBs.
These are usually oral drugs that get inside the cancer cell and interfere with specific signaling pathways that are driving its growth. For example, some inhibit angiogenesis, the tumor's ability to grow new blood vessels.
And because these are oral, at-home drugs, the nursing role changes.
It changes completely. The biggest challenge is adherence. You're sending a patient home with a bag of incredibly powerful and often toxic pills.
Yeah.
Nurses have to do intensive education on the dosing schedule, side effects to watch for, and how to handle and dispose of the medication safely.
Okay, let's pivot to the hands-on nursing management of the major complications from all these treatments. Let's start with maintaining tissue integrity and focus on stomatitis mucositis.
This is such a painful and debilitating side effect. It's caused by the chemo killing the rapidly dividing cells that line the mouth and GI tract. The key for nurses is a daily oral cavity check.
What are the interventions for a mild case?
The focus is on being gentle. Frequent normal saline rinses, super soft toothbrush, and avoiding any foods that are irritating, spicy, acidic, too hot or too cold.
And when it gets severe?
When you have open ulcers, you need to be culturing for infection. You've assessed their ability to swallow because of the aspiration risk. And you'll be using prescribed rinses that might have an anesthetic and an antifungal agent. Pain control is paramount.
And for radiodermatitis?
It's all about trauma prevention. No soaps, no lotions, no perfumes in the treatment field, just lukewarm water, no rubbing, no scratching, and absolutely no sun exposure.
Mm.
For moist desquamation, it's about using non-adhesive dressings and keeping it clean and dry.
What about the psychosocial impact of alopecia?
Hair loss is a huge blow to a person's identity and self-esteem. As a nurse, you have to talk about it proactively. Discuss getting a wig before hair loss starts. Talk about options like scalp cooling, but you have to know it's contraindicated in blood cancers.
And for the very difficult situation of malignant skin lesions?
These are often fungating, weeping lesions in advanced cancer. The care is purely palliative. It's about managing the symptoms, controlling odor, managing bleeding, keeping it clean, and aggressive pain control.
Let's talk nutrition. We mentioned CCS before. This isn't just a poor appetite.
No, CCS is a metabolic syndrome. The body is in a hypercatabolic, hyperinflammatory state. It's actively breaking down muscle and fat, regardless of what the patient eats.
So what can we do to fight the anorexia and weight loss?
We encourage small, frequent, nutrient-dense meals. We can try appetite stimulants like magistral acetate. But if oral intake just isn't enough, we have to escalate to enteral tube feedings or, in some cases, parenteral nutrition.
And pain management, often the most feared symptom.
And often poorly managed. The key is a thorough assessment: location, character, intensity. The guiding principle for intervention for the WHO algorithm is around-the-clock dosing.
So not waiting for the patient to be in pain.
Never. You use scheduled, long-acting opioids to maintain a steady state of analgesia and prevent the pain from breaking through. PRN doses are for breakthrough pain only, and you have to aggressively manage the side effects, especially constipation.
We also have to manage the profound fatigue.
This isn't normal tiredness. It's a persistent, distressing exhaustion that isn't relieved by rest. And ironically, the single most effective intervention is planned exercise.
Really?
Yes. A combination of aerobic, resistance, and flexibility training has been shown to be very effective. We also work on energy conservation strategies and good sleep hygiene.
And we can't forget the psychosocial side, improving body image and assisting in the grieving process.
So important. The nurse's role is to help the patient maintain a sense of control in the face of all these assaults on their body and their identity. We provide resources, support independence, and create a safe space for them to talk about their feelings.
Grieving isn't just about dying.
Not at all. It's about grieving the loss of health, independence, future plans. Our job is to support the patient and their family through that process, whatever it looks like for them.
Okay, let's get into our final section, the acute, life-threatening complications, starting with infection and neutropenia.
The #1 cause of death in many cancer patients. Neutropenia is a low absolute neutrophil count, or ANC. Risk goes way up when the ANC is below 1,500, and it's a severe risk below 500.
And the emergency is febrile neutropenia. Why is fever so critical here?
Because in a neutropenic patient, fever might be the only sign of a raging infection. They don't have the white blood cells to make pus or show other classic signs of inflammation.
So fever is a signal.
It's the fire alarm. A single temp over 101 is a medical emergency. You get cultures and you hang broad-spectrum antibiotics, often within the hour. Time is life.
And prevention?
Meticulous hand hygiene. Private room. No fresh flowers or raw foods. Avoid anything that could break the mucosal barrier, like rectal temps or enemas.
Next, bleeding and thrombocytopenia.
Thrombocytopenia is a platelet count below 100,000. The risk of spontaneous, life-threatening bleeding, especially in intracranial hemorrhage, gets very high when the count drops below 10,000.
What are the early warning signs we need to look for?
The earliest signs are petechiae and ecchymosis, those little pinpoint red dots and easy bruising. You also look for any occult blood or changes in mental status that could signal a brain bleed.
And the interventions are all about preventing trauma.
Soft toothbrush, electric razor, stool softeners to prevent straining, holding firm pressure on any injection sites. Just be gentle with everything.
Okay, let's run through the four big oncologic emergencies. First, superior vena cava syndrome, or SVCS.
This is when a tumor, usually in the chest, compresses the superior vena cava. It blocks blood return from the head, neck, and arms.
So what do you see?
Swelling of the face and arms, engorged veins on the chest, shortness of breath. The nursing priority is to keep the patient sitting up, monitor their breathing, and critically, no IVs or blood pressures in either arm.
Next, spinal cord compression.
A tumor is pressing on the spinal cord. The hallmark symptom is new or worsening back pain, especially pain that gets worse when they lie down or cough. This can rapidly progress to paralysis and loss of bowel and bladder function. It's an emergency that often requires immediate radiation or surgery.
Third, the metabolic emergency. Hypercalcemia.
This is when bone breaks down rapidly and releases too much calcium into the blood. Patients get confused, weak, nauseous, dehydrated. The primary nursing intervention is aggressive hydration, pushing 3 to 4 liters of IV fluid a day to help the kidneys excrete the calcium.
And last, let's revisit tumor lysis syndrome.
The metabolic catastrophe. Massive cell death releases potassium, phosphate, and uric acid. The big dangers are cardiac arrest from the high potassium and renal failure from the uric acid. Again, it's all about aggressive hydration and using drugs like resburicase to protect the kidneys.
We have to briefly mention the older adult population.
Yes, they are the majority of cancer patients, and they often have diminished organ function, which means they experience more severe toxicities from treatment and recover more slowly. Their care plans have to be carefully tailored.
And finally, we have to talk about cancer survivorship.
This is the next frontier of cancer care. It's not just about being cured, it's about managing the long-term consequences of the disease and its treatment. Every patient needs a survivorship care plan.
What does that include?
It's a roadmap. It details what treatments they had, what the long-term risks are, a schedule for surveillance and screening, and strategies for promoting health and wellness. It's about coordinating care for the rest of their lives.
And for patients with advanced cancer.
The goal shifts. It becomes about excellent palliative care, aggressive, around-the-clock pain management, maximizing their independence and control, and having those crucial conversations about end-of-life wishes and hospice care.
This has been a huge, incredibly dense deep dive. It's so clear that oncology nursing is about managing this lifelong multi-system disease, and so much of that complex care is now happening in the outpatient setting.
It really is. So for you, the caregiver listening, I think the essential takeaways are really threefold.
Okay.
1, safety first. You have to be able to instantly recognize the big emergencies. Febrile neutropenia means antibiotics now. Extravasation means stop the infusion now. And you have to know the unique toxicities of the new drugs, like IRAEs and CRS. Symptom mastery. Use the nursing process to be an expert at managing the things that affect quality of life the most.
Yeah.
Maintain tissue integrity and ensure effective around-the-clock pain control.
And the third?
Holistic view. You have to focus on the entire trajectory, from prevention through acute treatment and all the way into long-term survivorship and quality of life.
And as we close out, let's leave you with this final thought to take with you. Given that we are getting so much better at treating cancer and creating this vast growing population of survivors, what immediate practical steps can you take in your clinical practice tomorrow to integrate those four components of survivorship, care surveillance, prevention, intervention for consequences, and care coordination into every single patient encounter to make sure their long-term health and well-being are prioritized long after the acute battle is over?
That's the challenge that really defines modern nursing practice.
It certainly is. Thank you for joining us for this essential deep dive. We'll see you next time.